Good afternoon, everyone. I'm indeed privileged to meet you all in this platform, Facebook Live. Probably this is the first time for me, and I appreciate the initiative taken by CIPLA team. It's a wonderful one, knowledge sharing platform, wherein you can have the convenience of sitting in your OP room and you can listen to the latest updates. So, not taking much of time, I'd like to introduce myself to you all and also about the topic which I'm going to discuss with you. So I'm Dr. Karthikeyan, practicing pediatrics and neonatology in Chennai. I have a hospital, Sai Mother and Child Health Center in Kolkata. And I've been trained basically in the Institute of Child Health. So with this introduction, I will go to the topic, ethical vaccination practice. Why this topic? So you all know, and you'd all definitely agree to me that vaccination is the major part of our OP practice. We talk about diseases, we talk about disorders, we talk about the latest happenings in and around in our pediatric practice, but vaccination still forms a major chunk of our OP practice. So whatever we do in this vaccination or vaccine field, are we doing it right? So what is the ethics behind vaccines? So we'll definitely have few queries in our mind. It actually started as queries in my mind, which I put forward as queries to you, and I'll also try to answer. So I'll try to solve the myths that are around the vaccination practices and the reality that is there in vaccination practice. So we'll straight away go into the topic per se. So I'll just put forward certain questions. The answers will run in your mind. Those kind of answers I'll also try to tell them and we'll clear the doubts. So do all the neonates get BCG vaccination irrespective of gestation and weight? The general myth is 2 kilo. That is the weight that we generally that comes into our mind, and the term baby. That is the other thing that comes into our mind. But the evidence is, in general, any lower baby may be given BCG as the baby is ready to send home, and the cutoff as such is 38 weeks may be satisfactory, provided the baby has attained 1.8 kilogram, that is 1800 grams. With lesser gestational age, we can wait for the chronological age and wait to catch up to those necessary for sending the baby home. Babies weighing less than 1200 grams are usually not sent home until they have gained some weight, and thus the chronological age will be accordingly considered. And when they are ready to be sent home, probably they would have definitely attained this 38 weeks and 1800 grams. But still, some neonatologists have or might consider sending the stable baby home at a weight of around 1500 grams. But perhaps for such babies, the priority is not to give BCG early, but to wait until the baby has got up a weight of 1800 grams. In all these situations, we have to balance the need to wait until the baby's immune system is robust enough, for which purpose it is better to delay the vaccine and not to miss the opportunity of baby being available for vaccination. So this is regarding the BCG vaccination in preterms and low birth weight babies. So if that child had been given vaccine at 4 weeks of life, that is, you are discharging the child at 4 weeks of life, can we give the routine 6 weeks vaccination as scheduled? Or do we need to delay it further another 2 weeks and give it at 8 weeks? Good question, right? Tricky also. And generally, we have give a gap of 4 weeks. But the evidence is, irrespective of when the BCG was given to any baby who is doing well, can be given DPT at around 6 to 8 weeks of schedule, as scheduled. No need to have a gap of 4 to 4 weeks between BCG and DPT. The reason for that 6 to 8 weeks interval is for the maternal antibody to decline and for no other reason. DPT and OPV may be given concurrently with BCG or at any convenient interval after giving BCG. So, what is catch-up BCG vaccination. The moment I say catch-up vaccination, few ideas run into our mind. So whether the BCG scar is there or not, whether we need to give a tuberculin test, we need to do a MANTU test, see whether it is positive or negative, and then give BCG vaccination. So these are the myths behind this question. But the evidence is this: all these evidences have been taken either from our IAP, Indian Academy of Pediatric textbook on vaccinology, or the recent updates that has been done in the year 2019 by the ACVAP. So the recommended age of administration is at birth or at 6 weeks with other vaccination. Catch-up vaccination with BCG is recommended till the age of 5 years. The routine tuberculin testing prior to the catch-up vaccination is definitely not necessary. BCG may be repeated once in children less than 5 years of age in the absence of reaction or scar, presuming that the BCG has not been taken up. Even though most patients with absent reactions or scar have shown in vitro evidence of cell-mediated immunity against tuberculosis. Here again, tuberculin testing prior to administration of the second dose of BCG is not necessary. So the myth of doing a tuberculin test for a child is cleared. So this is regarding the catch-up vaccination. So this child who had given BCG at birth comes at 4 months with a bad BCG scar with secondary infection in ipsilateral axillary node. It's an ipsilateral axillary adenopathy. So what will be your approach? So the general answer from our fraternity will be go for an antibiotic. If it is not curing, go for drainage and go for antituberculous therapy. So this had been our way of treating for some time. But the evidence now, the secondary infection at the vaccination site may require antimicrobials. Ipsilateral axillary cervical adenopathy may develop a few weeks or months after the BCG vaccination. Antitubercular therapy is of no benefit in such situation and should not be administered. The nodes regress spontaneously after a few months. It should also be noted that if the needle aspiration cytology of the nodes is carried out, stain for acid fast bacilli may be positive, but these are all vaccine bacilli. In some children, the nodes may even liquefy and result in an abscess. So, surgical removal of the nodes or repeated needle aspiration is the treatment of choice. Again, ATT is definitely not recommended in such cases. Disseminated BCG infection is extremely unusual but may occur in children with cell mediated immunity. So, let us go to the next vaccine, our OPV. So OPV, we have been through trivalent, OPV, bivalent, now IPV. So we have a new word in polio vaccination, which is sequential schedule. So what is sequential schedule in oral polio vaccine? So we have the routine thing that we do is initial birth dose of OPV followed by 6, 10, 14 weeks of OPV, and we keep on continuing OPV vaccinations. But the latest recommendation is sequential schedule. That is, we still follow the birth dose of oral polio vaccine, followed by 3 primary doses of IPV. So in those 3 primary doses, there are no OPV at all. 3 primary doses of IPV at 6, 10, and 14 weeks, followed by oral polio vaccine at 6 months and another oral polio vaccine at 9 months. A booster dose of IPV at 15 to 18 months and oral polio vaccine at 5 years. So this is the sequential schedule. So what is the reason behind this sequential OPV vaccination? Do we have any benefit or do we have any um, advantage of giving this sequential OPV vaccination? Yes, definitely. So we all know there are two possibilities or problems with polio vaccine, especially oral polio vaccine. That is VAP, that is vaccine associated paralytic polio, and VDPV, which is vaccine derived polio virus. So there is considerable evidence to show that sequential schedules that provide IPV first, followed by OPV, can prevent this VAP while maintaining the critical benefits conferred by OPV, that is high level of gut immunity. So data from several studies shows that sequential schedule considerably decrease the risk of VAP. And there is a moderate level of scientific evidence that sequential immunization schedules starting with two or more doses of IPV followed by two or more doses of OPV gives a robust immunity, more than 90% of vaccines. So still the birth dose of OPV is as recommended as earlier. So it has not been changed. Still the birth dose of OPV is recommended. Providing the first dose of OPV at a time when the infant is still protected by maternally derived antibodies, at least theoretically, also prevents VAP. Though OPV at birth is not immunogenic, it enhances the seroconversion of subsequent polio vaccines, both OPV as well as IPV. And birth dose of OPV is definitely considered in countries like us where the risk of polio transmission is high. Even though we have eradicated, our neighboring countries still have polio virus. So, in your practice, how many IPV doses do you advise in primary immunization? And do you give OPV while giving IPV? For this question, partially I have answered in the previous slides, but this is the schedule given by IAP. Still, the birth dose of OPV is to be continued. Sequential schedule of IPV followed by OPV boosters at 9 months, 6 and 9 months. So, 1.5 years IPV booster and 5 year oral polio vaccine. It's not at 5 years, before 5 of the birthday. So let us go to the bread and butter of pediatric practice, that is the DTP vaccine. So regarding the DTP vaccine, again, this is the most debated question whenever we debate about vaccines. That is, either is it acellular pertussis or the cellular pertussis. What is the evidence-based practice in our country, in India? So previously in 2016, this was the recommendation, that is DTAP, acellular vaccine or combination should preferably be avoided for primary series. DTAP vaccine or combination should be preferred in certain specific circumstances or conditions only. And they also stated no need for repeating or giving an additional dose of whole cell vaccine to a child who has earlier completed the primary schedule with acellular vaccine. This was the recommendation in 2016. But this year, 2019, the ACPIP had modified the recommendations regarding the pertussis component. The primary series should be completed with 3 doses of either cellular or acellular pertussis vaccine, and they have made it clear that irrespective of the number of components in those vaccines, WP vaccine is definitely superior to acellular pertussis in terms of immunogenicity and duration of protection, but definitely it is more reactogenic. Sorry. And in our practice, private practice, and in view of parental anxiety and concerns for the reactogenicity, acellular pertussis can also be administered even in primary series. The primary aim is to increase the vaccine coverage. So we are well and good in using acellular pertussis vaccine, and we are going by recommendations of IAP. And so, just to throw more light on this cellular and acellular component, definitely the cellular pertussis vaccine holds good regarding the mechanism of action, which is Th1 basis and a better immunity. But by recommendations, we can use either of the vaccines. So now, this situation, each and every pediatrician in this country would have definitely faced, especially in the forthcoming months, might also end up in this problem. We had this problem a couple of months before also. So you are in a situation where the hexavalent vaccine brand that you use for 6 weeks had gone out of stock. So can the brand change to the another one, interchange at 10 weeks? So $1 million question. So you are you don't know what to do. The parents are asking you 100 questions. So you're changing the brand. So what should you do? Is there any evidence for interchanging the brands? Yes. So we do have evidence for interchanging the brands. Interchangeability of brands according to our IAP textbook of vaccination. In principle, the same type of either the cellular pertussis or acellular pertussis containing vaccine only should be given through the primary vaccine course. But, however, if the previous type of vaccine is unknown or unavailable, Any WP or AP vaccine may be used for the subsequent dose. You need not start from the first dose, may be used for the subsequent dose. So this is according to the recommendation. So let us go to the next one, which is hepatitis B. So what is the recommendation regarding hepatitis B vaccine for? Generally, we know that hepatitis B vaccine schedule, which is 0, 1, and 6, which has a better immunogenicity. So what is the recommendation regarding hepatitis B vaccine for preterm babies for a HPSAG positive mother and a HPSAG negative mother? So this is the question. So the answer will be more than 2 kilos, that is 2000 grams, as like any other full term child, it is 0, 1, and 6. So less than 2000 grams, the mother is HbsAg negative, but child is less than 2000 grams. Dose 1 at 30 days of age, dose 2 and 3 as per schedule adopted for full term infants. So this is the dosage for HbsAg negative mother. And for the mother is HbsAg positive, hepatitis B vaccine plus hepatitis B immunoglobulin within 12 hours of birth. Continuous vaccine series with 3 more doses beginning at 4 to 6 weeks of age as per schedule for full term infants. Immunize with 4 doses. Do not count the birth dose of vaccine in the series. Check anti-HPS and HPS-AG 1 month after completion of vaccine series. So this is the recommendation for preemies with HPS-AG positive mothers. So the next vaccine is pneumococcal vaccine, pneumonia. So we are left with 2 vaccines in this segment, the PCV10 and PCV13. So we will have a lot of debates regarding this. Is it the PCV10 or is it the PCV13? And the dosage schedule for the various ages. So I can say, according to the recommendations also, it is up to the practicing pediatrician to decide on whether PCV10 or PCV13. So generally, we take into consideration few things. If the child is high risk and the parents are affordable, better more strains. So PCV13. And if the child or the parent is not affordable, don't send them out of the clinic without immunization just for the want of difference in the cost. So you can provide them with PCV10 also. So what is the dosage schedule for these vaccines? So the primary series, the PCV13 is 3 doses between 6 weeks to 6 months. If the child is seen between 6 weeks to 6 months, it is 3 doses. Between 7 months to 11 months, it is 2 doses, the primary series. 12 months to 24 months, that is still second year, it is again 2 doses. And more than 2 years, the primary series will be 1 dose for the PCV13 and 2 doses for the PCV10. It is 2 doses for PCV10. We have to have it in our mind. And regarding the booster dose, so it will be the same for both the type of vaccines in the primary series between 6 months to 1 year. So again, so we talked about interchangeability of the DTP vaccine. Is this PCV10 and PCV13 are interchangeable? Luckily, so far we have not got in the situation where one vaccine is available and the other vaccine is not available. But is it interchangeable for some other reason? If the mother is or the parent is saying I'm not affordable, so can I give the another vaccine, the lower cost vaccine? So when the primary immunization is initiated with one of these vaccines, the remaining doses should be administered with the same product. There is no interchangeability study in among PCV10 and 13. However, if it is not possible to complete the series with the same type of vaccine, the other PCV product should be used with the entire full course. Rotavirus. So we are left with rotavirus vaccine now. 3 or 4 companies we have, 3 or 4 strains we have. So is it the RV1, RV5, 116C, or the lyophilized vaccine? So what are all the advantage, disadvantage between these vaccination, and what kind of or what type of vaccines do you use? So the evidence is according to the ACBIP IAP recommendation on rotavirus vaccine, that is 2019, any of the available rotavirus vaccine may be routinely administered as per manufacturer's recommendation. All the available vaccines have been demonstrated to be safe and immunogenic. The minimum age is 6 weeks for all available plans. So previously we had a confusion. The RB1 was placed at 10 weeks. So now it is 6 weeks uniformly for all the available brands. Only two doses for the RB1 brand at 6 and 10 weeks. If any of the dose in the series was RV5 or 1160 or vaccine product is unknown, the total of 3 doses of RV vaccine should be administered. And recommendations on age limit for the first dose and the last dose continues to be the same. So I'll be following it up with the next question, which is regarding catch-up rotavirus vaccine. So what is rotavirus vaccine schedule and what is catch-up RV schedule? So 8-month-old baby is brought to your clinic, but with not given even a single dose of rotavirus vaccine. Will you initiate or will you start vaccinating the child? Or a 6-month-old child. So we can say, keep it at 6 months. Will you initiate the vaccine? Because the last vaccine, according to recommendation, is 8 months. So 6, 7, 8, can we give that kind of doses? So the evidence here is the minimum age 6 weeks for both RV1 and RV5, and only 2 doses for RV1 are recommended. RV1 should preferably be employed in, so this was the older one. So I'll tell you about the catch-up vaccination. The maximum age for the first dose in the series is 14 weeks and 6 days. So we have to have this in mind. The maximum dose time limit or the age limit for the first dose is 14 weeks and 6 days. And vaccination should not be initiated for infant aged 15 weeks onwards. So more than 15 weeks of age, do not initiate rotavirus vaccine, and you are against recommendation and against evidence also. And the maximum age for the final dose is 8 months for rotavirus vaccine. So moving forward, hepatitis A vaccine. So again, we have availability issue in this type of vaccine. We have 2 doses, 2 types of vaccine, the live vaccine and the inactivated vaccines. So we are still not very comfortable in using Chinese vaccine in some situations. But are we good in using the hepatitis live vaccine, 1 or 2 doses? What are the recommendations? So here is the recommendation. So if a decision to administer the vaccine is taken, any of the licensed vaccine may be used as all have nearly the same safety and efficacy. The WHO concludes both inactivated and live attenuated hepatitis A vaccines are safe and highly immunogenic, and that in most cases the vaccines will then generate long lasting, possibly lifelong protection against hepatitis A, both in children and adults. So this is the recommendation. So you are not doing any harm in using the live vaccine. So it is as good as the attenuated or inactivated vaccine. A higher geometrical mean titer of anti-hepatitis A virus IG was induced in 2 doses inactivated than in 1 dose inactivated and attenuated vaccines at 12 months. Compared to the classical 2 dose schedule, the one single dose of inactivated hepatitis A vaccine is similarly efficacious, less expensive, and easier to implement. High efficacy of post-exposure prophylaxis against hepatitis A using one single dose of inactivated vaccine with 2 weeks of exposure, within 2 weeks of exposure, is also documented. So we'll move on to the next vaccine, which is the MMR vaccine. So now there had been a lot of confusion regarding where to place this MMR vaccine. So is it at 9 months? Is it at 15 months? Is it at 5 years? So where will you place? How many doses of MMR vaccines are you going to give? So according to the recommendation here, this is the latest one in 2019. Standalone measles vaccine is now not available for regular use. Measles containing vaccine, that is either MMR or MR, should be administered after 9 months of age. MR vaccine is currently only available in the government setup. Hence, in view of morbidity following mumps infection, it has been recommended that MMR is administered instead of MR at 9 months, 15 months, and 5 years, or as 2 doses at 12 to 15 months of age, with a second dose at 4 to 6 years. So this is the recommendation, latest one. An additional dose of MR vaccine during MR campaign for children 9 months to 15 years, irrespective of previous vaccination status, is to be administered, keeping in mind to support the national program. So when a child or when a parent is asking you whether should we vaccinate this national program, MR vaccine, they are coming and giving in the school, you should never say no or deny it. So according to recommendation, you should say yes, and it does also imperative. Chickenpox. So, which varicella vaccine and what schedule will give maximum protection? So, the evidence is for primary immunization, the first dose should be given at 15 months and second dose at 4 to 6 years. However, during an outbreak, the first dose may be administered at 12 months of age and ensure that the second dose schedule will be two dose schedule will be continued or completed by the individual child. Second dose may be administered at any time between 3 months after the first dose. So for catch-up vaccination, children below the age of 13 years should receive two doses 3 months apart, and those aged 13 years or more should receive two doses at an interval of 4 to 8. So this is the catch-up for chickenpox. All high-risk children should, however, receive two doses 4 to 8 weeks apart, irrespective of the age. So typhoid vaccine has. So we all know that the conjugate vaccine has stolen the show. Are we justified? So we have been using oral typhoid vaccine. We have been using the typhoid encapsulated capsular VA polysaccharide vaccine. Now we have moved on to conjugate vaccine. And this has stolen the show. Are we really justified in using this? And what is the evidence and what is the recent recommendation? So this is the difference between basic difference between the polysaccharide and the conjugate vaccine. The T cell dependent immune response is robust in the conjugate vaccine. Immune memory is robust. Effectiveness less than 2 years is evidenced in conjugate polysaccharide vaccine. Efficacy is high, and post-booster immune response is robust, and IgG class switch is efficient for conjugate polysaccharide vaccine. So, what is the optimal dose? We do have three vaccine forms available with a dosage of 25 microgram and 5 microgram. Two belong to the 25 microgram category and one belongs to the 5 microgram category. The evidence says currently three products of TCV are licensed in India. Two of them have 25 and one 5 microgram. The WHO position paper 2018 has remarked that the body of evidence for 5 microgram vaccine is very limited. So we have to use the 25 microgram vaccine. And ACVIP recommendation, a single dose of TCV 25 microgram is recommended from 6 months onwards. An interval of at least 2 weeks is not mandatory between measles containing, that's MMR vaccine, and typhoid vaccine, which we used to do previously. So you can give measles vaccine or MMR, not measles one, MMR vaccine along with typhoid in your, if you have that 9 month schedule. And for a child who has received only typhoid polysaccharide vaccine, a single dose of TCV is recommended at least 4 weeks following the receipt of the polysaccharide vaccine. So this is the latest evidence for typhoid. So the last, probably I'm coming to the end of our discussions. So quadrivalent or bivalent human papilloma virus. So what is the recommendation? So we have now, the pediatrics has moved from infants, toddlers to adolescents now. So we'll have to take care of adolescents also. So we need to know about adolescent vaccine. So the minimum age for giving this HPV vaccine is 9 years. We have two products available, HPV4 and HPV2. So the schedule is 026 for HPV4 and 016 for HPV2. This is the recommendation in 2016. HPV4 can also be given in a 3-dose series for males, but it is not licensed in India. So administer the second dose 1 to 2 months after the first dose and third dose 6 months after the first dose. But the latest recommendation is 2 doses for both types of vaccination. Administer the vaccine series to females at the age of 13 through 45 years if they are not previously vaccinated. So, coming to the vaccine of the season. So, influenza vaccine. What is the best time of the year to give influenza vaccine? So, you have a child who was born in the month of November. So probably I'm talking about South India. So the child was born in the month of November, and they are bringing the child to you in the month of May for flu vaccine. That is routinely we have the schedule of flu vaccine at 6 months. They are coming to you, bringing to you at 6 months for flu vaccine. So will you recommend it? Will you recommend it or will you give it? So the recommendation is ACDIP recommends that quadrivalent or trivalent inactivated influenza vaccine should be routinely offered annually to all children between 6 months to 5 years. It is not imperative that children more than 5 years do not need. The recommendation limits to 5 years, but definitely we can give it yearly, then onwards also. The latest available influenza vaccine can be administered after 6 months of age, 2 to 4 weeks prior to the influenza season. So if it is Mumbai, probably now definitely you should have vaccinated. For Chennai, we could vaccinate it 1 month later also. And one dose annually before the influenza season up to 5 years of age. So the your views on rabies vaccination. So and what is RVIG? So we have newer ones RVIGs here. That's why I've just put in the slide also here. So in view of irregular availability and high cost of rabies immunoglobulin, ACBAP now endorses the use of RHMAV, that is the alternative to RAG, human or equine along with rabies vaccine in all category 3 bites. This rabies shield is licensed in India since 2017 and the recommended dose is 3.33 IU per kilogram body weight, preferably at the time of first vaccine dose. However, this may also be administered up to 7th day. You should note this point, up to 7th day after the first dose of vaccine is given. If the calculated dose is very fractional, it can be mixed in saline to improve the volume and you can infiltrate around the wound. So, summarizing the latest recommendation of IAP, so I need not, I'll just rush through this slide because I've done this extensively. So, next will be the site of vaccination. So, I still see a lot of babies being vaccinated in the gluteus region. So, is it safe to inject in gluteus region? Are we ethically correct in vaccinating the child in gluteus? And if at all there happens to be any medical legal problem, are we protected by giving this vaccine in gluteal region? Definitely no. This chart clearly states the site to be administered, the type of syringe to be used, the angle to be administered. So this is available in our IAP textbook of vaccination. You can go through this slide. So it is definitely not in the gluteal region. It should, if it is an intramuscular injection, it should be in the anterolateral side. If it is BCG, it is in the left upper arm, which is an intradermal injection. If it is MMR, it should be in the right upper arm, which is a subcutaneous injection. So again, we have done about the vaccine, but still, touch wood, we should not get this complication, but there happens to be a vaccine associated problem. So, adverse event following a vaccination. What are the minimum resuscitative equipment that we should have in our office? So, this chart is definitely very important. An airway, ambu bag, mask, IV access, oxygen cylinder definitely should be there in your office practice. And if you are in a tier 2 city or access to oxygen cylinders or B-type cylinders not available. Oxygenators are not always available, especially one brand BPL oxygen generator is wonderful. It generates even up to 10 liters of oxygen, so it can be safely used. IV hydrocortisone and normal saline. So where to store? So do we all have ILRs? No, even I don't have an ILR now. So we still store in the refrigerator, but that we use in our kitchen. So where to store the vaccine? What all to store in that? I have probably in my earlier times of practice, I have kept my water bottle in the fridge. So then only after seeing all these recommendations, I have come to know that nothing other than the vaccine should be placed in your refrigerator, not even the chocolate that your patient gives for your birthday, no, or his birthday. It should not be stored in the refrigerator. Nothing other than the vaccine. And this chart clearly shows where the vaccines should be stored. Nothing in the door. So the door should be free. No vaccine should be placed in the door. Ice cubes and OPV vials in the freezer compartment. The top, the more thermolabile vaccines like BCG, measles, chickenpox, those in the top. The middle compartment comprises of the DPT vaccine, hepatitis A, B vaccine, and diluents in the lower part where you generally store your vegetables in your kitchen. That is the vegetable tray is for your diluents. So, so we have done with the vaccines now. So the last part of the talk will be, it should not happen to any of us, but definitely it will have happened to one or two sporadic cases. So adverse event following immunization. Whom should I report? So I had a child who was throwing a fit after the vaccine. Whom should I report? So don't panic. So there is the easy way to report, and it has to be reported. It has to be documented. What is adverse event following vaccination? Any happening, starting from a mild fever to a major thing like a convulsion or a death, is an adverse event. But according to recommendation, an AEFI is defined as a medical incident that takes place after immunization, which causes concern and it is believed to be caused by immunization. Only serious AEFI that includes deaths, hospitalization, clustering of cases, and disability is reported to the system. And this is the website, which is the idserve.org. Just go into this website. There will be a column stating report AEFI. Just click that column. You will be having a drop down menu. Fill up all those details and upload it. You are safe. So this is the thing you should have. And the private practitioner should use the FIR form for reporting the serious AEFI cases to the district officials. Once the AEFI is reported from a private sector, the district official and the district AEFI committee members would then investigate and report the AEFI case. So the pediatrician should help investigation team in collecting all the related information. And this is again the same thing, online reporting, how it's been done. So integrate IAP disease surveillance project. That's integrate IAP disease surveillance project. This is the full form for ID serve. And with this, I'd like to close my talk. Thank you for the patient listening. Hope this topic would have been useful for your practice. So not only listening to this topic is important, so we should take it further and practice it in our next session also. Thank you.